Anticoagulation Principles, DOACs, Part 3, Management of DOAC Bleeding. Hi again everybody, and welcome to another installment of the PharmEasy Tutor. Today we will complete this three-part lecture series by focusing on the treatment of bleeding caused by the DOACs. First, let's go over some key tips when counseling a patient taking DOACs. Here are some patient counseling reminders that apply to all three of the DOACs that we are studying. The patient should monitor for bleeding or bruising and be told that it may take longer than usual to stop bleeding. They should not discontinue the DOAC before talking to a physician first. They need to tell the physician and dentist that they are taking a DOAC. They should be counseled on what to do if a dose is missed, and the patient needs to be reminded to contact the physician if starting aspirin or NSAID therapy. With regards to food, apixaban and dabigatran can be taken with or without food. For rivaroxaban, the patient needs to be advised when to take with food or without food. Remember, the higher doses of rivaroxaban must be taken with food to improve its bioavailability. If the patient can't swallow very well, apixaban and rivaroxaban can be crushed and put in applesauce. However, for dabigatran, the capsules cannot be opened. The patient must take the capsule whole. Also, advise the patient that the capsule should be taken with a full glass of water. For patients taking dabigatran, they need to be reminded to keep the capsules in the original bottle to protect it from moisture and not put the capsules in pill boxes or pill organizers. They need to remove only one capsule from the open bottle at the time of use and tightly close the bottle immediately. Let's switch gears now and talk about bleeding caused by DOACs. All anticoagulants predispose to a risk of bleeding. As a class, the DOACs exhibit comparable efficacy and a lower bleeding risk compared with warfarin among patients with VTE and non-valvular atrial fibrillation, and most importantly, a significantly lower risk of intracranial hemorrhage. Nevertheless, patients taking DOACs may present with serious bleeding or need for an urgent unplanned procedure. Major bleeding was reported in 2.1 to 3.6% of patients randomized to treatment with a DOAC in phase 3 clinical trials. Whenever we discuss bleeding severity, we need to define what a major bleed is. Major bleeds are bleeds associated with hemodynamic compromise occurring in an anatomically critical site, for example intracranially, or associated with a decrease of hemoglobin greater than or equal to 2 grams per deciliter, or requiring transfusion of greater than or equal to 2 units of packed red blood cells. Any life-threatening bleeding is considered major. Non-major bleeds are all bleeds not classified as major. Some non-major bleeds may require intervention or hospitalization. So what are the antidotes or reversal agents that we use in life-threatening or major bleeds caused by the DOACs? Let's first talk about reversing dabigatran. For dabigatran reversal, the antidote for dabigatran is idarucizumab or Praxbind. Idarucizumab or Praxbind is indicated for the reversal of the anticoagulant effect of dabigatran for emergency surgery or urgent procedures or life-threatening or uncontrolled bleeding. It was approved in October of 2015 and manufactured by Boehringer Ingelheim. It has a rapid onset of 5 minutes and the effect lasts for 24 hours. Mechanism of action. Idarucizumab is a humanized monoclonal antibody fragment, FAB, that binds with a high affinity to dabigatran in its metabolites. You can see in the diagram to the right how idarucizumab binds to the dabigatran molecule. When bound, The drug neutralizes the anticoagulant effect of dabigatran, allowing thrombin to resume its role in the anticoagulation cascade. Idarucizumab binds to dabigatran and its metabolites at a higher affinity than the binding affinity of dabigatran to thrombin. The idarucizumab dabigatran complex is renally cleared. However, no dose changes are needed in patients with any degree of renal dysfunction. The dose of idarucizumab is 5 grams IV. It's administered as two separate 2.5 gram per 50 ml vials given consecutively. You can see in the picture to the right how idarucizumab can be given in IV piggyback fashion. If bleeding persists and there is laboratory evidence of persistent dabigatran effect after 12 to 24 hours, a second dose may be reasonable. Unlike reversal agents that contain coagulation factors, idarucizumab is not thrombogenic and therefore has a low risk of leading to a thrombosis after administration. However, using this agent for reversal will expose patients to a thrombotic risk. Other notes. Hemodialysis can be considered if the drug level is high, especially in patients with poor renal function. With hemodialysis, approximately 49% of the total dabigatran can be cleared from plasma over 4 hours. Fresh frozen plasma is not recommended for DOAC reversal. If idarucizumab is not available, consider using 4-factor PCC or Kcentra, 50 units per kilogram IV. Refer to the prescribing information for maximum units. Administration. A pre-existing intravenous line may be used for administration. The line must be flushed with sterile normal saline prior to infusion. Storage. Idarucizumab needs to be stored in the refrigerator in the original carton to protect it from light. Do not freeze and do not shake the vials. The vials may be stored at room temperature for up to 48 hours in the original carton, protected from light. Vials placed out of the carton and exposed to light must be used within 6 hours. The cost of idarucizumab is approximately $5,000 for a 100 ml treatment dose. Now let's talk about the reversal of the DOACs apixaban and rivaroxaban. The antidote for apixaban or rivaroxaban is Andexanet or Andexa. Andexanet is an inactivated recombinant modified human coagulation factor 10A protein. It's indicated for patients treated with rivaroxaban or apixaban when reversal of anticoagulation is needed due to life-threatening or uncontrolled bleeding. It was approved in May of 2018 and manufactured by AstraZeneca. It is not to be given for edoxaban overdoses. Andexanet is a modified factor 10A molecule that binds directly to free-floating oral factor 10A inhibitors to negate their effect. Andexanet acts as a decoy and sequesters rivaroxaban or apixaban, inhibiting these drugs from binding to natural factor 10A. Andexanet rapidly reduces the free plasma concentration of the factor 10A inhibitors rivaroxaban and apixaban and neutralizes their anticoagulant effect. Andexanet is administered as a bolus with continuous infusion. Dosage. The recommended dose of Andexanet is based on 3 things. 1. The specific factor 10A inhibitor. 2. The dose of factor 10A inhibitor. And 3. The time since the patient's last dose of factor 10A inhibitor. We need to refer to the following 2 tables to determine the specific dose of Andexanet. We will use the following table to determine whether we will be using a low dose or a high dose Andexanet dosing regimen. First, rivaroxaban. If the rivaroxaban dose is less than or equal to 10 milligrams, and the time since the last dose was taken was less than 8 hours or is unknown, then a low dose Andexanet regimen is selected. If the rivaroxaban dose is greater than 10 milligrams or is unknown, and the time since the last dose was taken was less than 8 hours or is unknown, then a high dose Andexanet dosing regimen is selected. For either doses of rivaroxaban, if the time since the last dose was taken was greater than or equal to 8 hours, then a low dose Andexanet dosing regimen is selected. For apixaban, if the dose is less than or equal to 5 milligrams, and the time since the last dose was taken was less than or 8 hours or is unknown, then a low dose Andexanet regimen is selected. If the apixaban dose is greater than 5 milligrams or is unknown, and the time since the last dose is taken was less than 8 hours or is unknown, then a high dose Andexanet dosing regimen is selected. For both apixaban doses, if the time since the last dose was taken was greater than or equal to 8 hours, then a low dose Andexanet dosing regimen should be used. The low dose Andexanet dosing regimen consists of a bolus dose of 400 milligrams given over 15 minutes, followed by a continuous infusion of 480 milligrams or 48 mLs over 2 hours, running at a rate of 4 milligrams per minute or 24 mLs per hour. The total number of 200 milligram vials of Andexanet that's needed for this regimen is 5, 2 for the bolus dose and 3 for the infusion. The high-dose Andexanet regimen consists of an 800 milligram bolus dose given over 30 minutes, followed by a continuous infusion of 960 milligrams or 96 mLs over 2 hours, running at a rate of 8 milligrams per minute or 48 mLs per hour. The total number of 200 milligram vials of Andexanet needed for this regimen is 9, 4 for the bolus and 5 for the infusion. Let's go over the steps on how to prepare Andexanet. First, the bolus dose. Dilute each 200 milligram vial with 20 mLs of sterile water for injection. Use a 20 gauge or higher needle. Slowly inject the water and direct the solution onto the inner wall of the vial. This minimizes foaming. Do not shake the vial. Gently swirl each vial in a rotating fashion. It should dissolve in about 3 to 5 minutes. Use a 60 ml syringe with a 20 gauge needle to withdraw the volume from the vials. Transfer the total solution into an empty sterile bag. Now let's talk about preparation of the infusion dose. Start the infusion dose 2 minutes after the bolus dose has been administered. Prepare the infusion dose using the same procedure as the bolus dose. More than one 60 ml syringe may be needed. The low-dose Andexanet infusion dose is 480 milligrams or 48 ml, and the high dose is 960 milligrams or 96 ml. Dispense the infusion with a 0.22 micron low-protein binding filter. Administer Andexanet intravenously using a 0.2 or 0.22 micron inline polyether sulfone or equivalent low-protein binding filter. The stability of the prepared Andexanet bag is 8 hours at room temperature. The stability of the reconstituted vial of Andexanet is 8 hours at room temperature and 24 hours refrigerated. Fresh frozen plasma is not recommended for DOAC reversal. If Andexanet is not available, consider using 4-factor PCC or Kcentra, 50 units per kilogram IV. Refer to the prescribing information for the maximum units. Storage. Unopened vials of Andexanet should be stored refrigerated at 2 to 8 degrees centigrade, 36 to 46 degrees Fahrenheit. Do not freeze. Here is the cost of Andexanet. For the low-dose regimen, or 5 vials, the cost is $12,500. For the high-dose regimen, or 9 vials, the cost is $22,500. Andexanet carries with it a black box warning. Treatment with Andexa has been associated with serious and life-threatening adverse events, including arterial and venous thromboembolic events, ischemic events including myocardial infarction and ischemic stroke, cardiac arrest, and sudden death. Let's review idarucizumab. Idarucizumab, or Praxbine, is the antidote for life-threatening bleeding caused by dabigatran. It is a monoclonal antibody fragment that binds to dabigatran and its metabolites and neutralizes them, allowing thrombin to continue to act in the clotting cascade. It is available as 2.5 gram in 50 ml bottles. The total dose of reversal is 5 grams or 2 of the 50 ml bottles. The cost of 5 grams is approximately $5,000. Now let's review Andexanet. Andexanet, or Andexa, is the antidote for life-threatening bleeding caused by apixaban or rivaroxaban. It's a modified factor Xa molecule that binds directly to free-floating oral factor Xa inhibitors to negate their effect. It is administered as a bolus dose followed by an infusion. The recommended dose of Andexanet is based on the specific factor Xa inhibitor, the dose of factor Xa inhibitor, and time since the patient's last dose of factor Xa inhibitor. Tables are available to select either the low-dose or high-dose regimen. The cost of each treatment ranges from $12,500 to $22,500. If Andexanet is not available, administration of 4-factor PCC or Kcentra should be considered. In Part 3, we explained how to counsel a patient taking DOACs, described the use of DOAC antidotes in cases of severe life-threatening bleeding, and outlined the dosage and proper procedures in the preparation of idarucizumab and Andexanet. We've got a lot in store at the PharmEasy Tutor channel. There will be upcoming talks on electrolyte management, migraine review, atrial fibrillation treatment, shingles vaccine, drug overdose, and much, much more. So please stay tuned to us. Thanks for tuning in to watch this installment of the PharmEasy Tutor. I hope you learned something that you could use at school or in practice. If you would like to continue to see more of these types of tutorials on YouTube, please make sure to click on the black subscribe button below to change it to the word subscribed. Also, if you like this video, I would appreciate it if you can click on the thumbs up icon below to change the color to black. Also, if you have any comments or questions, please feel free to add them in the comments section below or share this site with someone else. Stay tuned to the PharmEasy Tutor channel for more lectures in the upcoming weeks. So until next time, remember to take it easy.